All right, good evening, everyone. It's really great to see you. We're into our session number 7 for this Project Echo course, and we're really glad that you've been able to join us tonight. I see lots of people joining in. If you have a minute to introduce yourself on the chat, we would love to get to know you. We have many of our faculty members with us tonight. You can see a hashtag in front of them. They'll take a minute now and introduce themselves on the chat as well. I'm Erin, a palliative care nurse from Canada, supporting this program from Kenya. And I'm really excited to be here today and help facilitate the call. We'll be talking about children's palliative care, and we're really honored to have the leader of ICPCN, Professor Julia Downing, with us, who will be taking us through some content on children's palliative care to learn more about how to provide holistic care to children and their families that are dealing with life-threatening or life-limiting illnesses. And we know that you most likely see the whole lifespan of individuals, not only adults, but we know you probably do see a lot of children, adolescents, and maybe even neonates or infants. So we're hoping that this session will be really informative for you.
Okay.
Just the ground rules again, try to stay muted if you're not presenting. If you have a question, you can raise your hand. In the very bottom of the Zoom, there is a reaction and there's an option to put your hand up. We would love to have a time of discussion after the presentation is finished. Please do introduce yourself in the chat with your name, where you're working, so we can get to know you more. Yes, after the initial lecture or presentation, we'll be having a case that is going to be shared, and I'll introduce the case presenter then. Thanks again, everyone, and I'll pass it over to Julia. We're glad that you're here with us today.
Thank you very much. Let me just share my screen. Can you see that okay?
Yeah, thank you.
Yes, we see it, yeah.
Great. So I'm really pleased to be here today, and I'm delighted to be working as well with my colleague and friend Joan Marston, who was the first Chief Executive of the International Children's Palliative Care Network. So I am building on all that she has already done. As Erin said, my name's Julia. I'm the Chief Executive of the International Children's Palliative Care Network. I'm also a professor in palliative care at Makerere University in Uganda. And I've had the privilege of coming to Lesotho on many occasions, initially when I was working with the African Palliative Care Association, and then through the work with the International Children's Palliative Care Network. So I'm going to talk to you, and also, sorry, I'm a nurse by background as well. So I'm going to talk to you about children's palliative care. And I think it's always good to start with a focus on what we're trying to do. And within palliative care, we know that we are trying to improve quality of life. And we want to improve the quality of life of the children that we care for, whether they have an hour, or a few days, or a few weeks, months, or years left to live. We want to do all we can to ensure they have the best possible quality of life. So you've been learning about palliative care over the weeks, and you will be familiar with the World Health Organization definition of palliative care. And the World Health Organization also has this definition of children's palliative care. I like this because it talks about the total care of the child's body, mind, and spirit, talks about providing care for the family, talks about beginning when illness is diagnosed. And for many of us in sub-Saharan Africa, there might not be a diagnosis, maybe because the child presents late with advanced disease, or because we don't have access to the diagnostic treatments or finances. So as soon as it is recognized that the child needs palliative care, we should be providing it. I also like this because it talks about a multidisciplinary approach. And I know that on this call, we are from a range of disciplines and we need to work together. Palliative care can be provided when resources are limited, and we provide care wherever we find the child and their family. All components that are so important for us. So In this session, I'm just going to talk about some of the key principles of children's palliative care, and I'll point you in the direction of more resources if you would like to read more. But I think as we think about the paediatric palliative care, some of the key features are that it's providing relief from pain and other distressing symptoms. We know that there are 21 million children at least globally that need access to palliative care. Only around 5% of those have access. And so we know that there are millions of children around the world who are suffering when they needn't. And so we need to be developing paediatric palliative care so that we can help improve the quality of life for these children and their family. It's around holistic care. It's for children with cancer, but also importantly, those with a non-cancer diagnosis. Many people often think about palliative care just for children with cancer. And yet, if you look at the range of children that need access to palliative care, children with cancer make up only around 6 to 7% of the wide range of children needing palliative care. It's about active care. People think that you get palliative care when nothing more can be done. And we can always do something. It's not about giving up. It's about ensuring that we accompany the child and their family throughout their illness. And we look at how best we can improve their quality of life. We talk about an interprofessional team. We've mentioned the fact that it's about wherever the child needs care. And importantly as well, it's not limited to the last few days or weeks of life. And it can be provided alongside treatments to control or cure the disease. So another question we often get asked is, when is the best time for palliative care to begin for a child with a life-threatening disease? I've already given you the answer, but it's so important that we start providing palliative care when the child is first diagnosed or recognized as having a life-threatening disease. We don't want to see children and their families just a few days before they die. We want to be able to have an impact on their care before that. So as soon as it is evident that a child has a life-limiting or life-threatening condition, we want to be beginning to provide palliative care. So we know that it is appropriate, and this is just a reiteration from the World Health Organization, but also from other palliative care organizations, that we need to be offering care right as early on as we can, right through the course of their illness. I like this. It's called the bow tie model, but I like this because it shows that at diagnosis, maybe the care is more aimed at disease management, but we begin to input in palliative care, and then that will change as a child perhaps moves throughout the disease progression to end of life and into death and bereavement. But it shows clearly that the two should be going hand in hand, disease management and palliative care. And there are many myths, and again, I've mentioned some of them, but we shouldn't be saying nothing more can be done. There is always something that we can do. And it's important that the parents, that the family know that we are there with them. Again, we hear that people say palliative care is only available when no disease-directed care is possible. Sadly, in many cultures, there's a fear that if you talk about death and dying, or if you talk about providing palliative care, it will bring the child's death sooner. Sometimes people think it must be given at home or it must be given in the hospital, whereas in reality, we provide palliative care wherever we find a child and their family. And also we hear that it can't be provided in humanitarian settings, or it can't be provided in low resource settings. And we know that it can. So we know that there are many myths around children's palliative care. So as I mentioned earlier, The children that need access to palliative care. This is from the recent atlas in children's palliative care. And you can see that there's a wide range of children needing access to palliative care. Those with HIV disease, those with injury, a large proportion, over 30%, with premature birth and birth trauma or congenital malformations. There's some with protein energy malnutrition. Yes, of course, if we can reverse the malnutrition, we need to do so. But we know that there are some children for which that won't be possible. So you can see a wide range of conditions that children may have who need access to palliative care. And there's work being done. Now, this work has been done in the UK, but we're in the process of looking at this in a global context in terms of trying to identify the different groups of children that need access to palliative care. There are those with children with life-threatening conditions for which curative treatment may be feasible, but it can fail. Maybe there are treatments for cancer, but maybe the child has presented late. We know that around 80% of children with cancer in low-income settings will present with advanced disease. Conditions where premature death is inevitable. Progressive conditions without curative treatment options. And then there's some irreversible but non-progressive conditions causing severe disability that can lead to susceptibility to health complications and likelihood of premature death. Plus neonates, plus in many palliative care programs across sub-Saharan Africa, bereavement care and providing bereavement support to children is another key area of care provision. But one of the things that we often talk about in children's palliative care, and indeed in adult palliative care, but particularly in children, is that we hope for the best, but we plan or prepare for the worst. In talking with families of children perhaps who've got cancer, we might be saying that we're hoping that this chemotherapy is going to cure your child, but at the same time we need to plan for the fact that it might not do so, or that there might be severe complications and side effects. So throughout the process, we can be hoping for the best, but planning for the worst. So I'm just going to touch briefly in the next few minutes on some of the principles of palliative care in children. Now, some of the overarching principles might be similar as with adults, but we know that children are not just little adults. We know that children have their unique needs. There are unique challenges in working with children needing palliative care. There are challenges in working with their families. There are the cultural issues around communicating with children. When should children be involved in decision making? What should children be told? There are cultural issues around who makes the decisions in the families. There are different conditions that we need to know about in children than there are in adults. So there are many differences between palliative care for adults and for children. So let's just think of some of the principles. So firstly, it is about providing care across the whole continuum of care, from diagnosis through to death and into bereavement, across a variety of care settings, providing palliative care whenever the child and their family would benefit from it. And the fact that palliative care is not a last resort, but an essential component of care. Now, some of these things I'm reiterating because it's so important, and many of these myths have grown within our settings. And it's interesting that in the same voice, we might be saying that people don't know about children's palliative care. Oh, but people think it's only for the end of life. So it's really important that we as health professionals are aware of the need for palliative care across the continuum, and that is the message that we are giving. It's important that we provide care wherever the child and their family are. That palliative care might be in a hospital, it might be through a clinic, it might be through a hospice or a palliative care program, it might be at home, it might be at school, or it might be in a children's home, such as Sunflower, where Joan has works. So there are many different places where we provide palliative care. Of course, pain and symptom management is an essential component of care, but that's not all that we do. But managing pain, managing symptoms is so important. And crucially, it's not just related to the child's condition, but to the treatment as well. Let's not forget procedural pain, the pain of taking blood, the pain of giving injections. Let's think about pharmacological and non-pharmacological pain and symptom management. And let's get this right from the start. We know that children who experience a lot of pain early on, it will then get harder and harder to manage their pain. Let's try and manage their pain right from when they first present with pain and other symptoms. And let's not forget the issue of total pain, and it's there in children as well as in adults. So then, of course, emotional support, so important for all children, regardless of their age. Often we find, particularly children with HIV, particularly children with cancer, that they might have friendship groups with other children with similar conditions. And that can be helpful. It can help them, particularly the adolescents and the older children, that they want to talk with others going through similar situations. They want peers going through similar situations so that they don't feel quite so isolated and quite so different from everyone else. It's important that we find ways of providing emotional support for the child and for their family. And let's not forget the grandparents, particularly in our settings where the grandparents often help raise the children, and also the siblings. And what about the other children? What in their communities? We talk about the fact that it takes a village to raise a child. And so we need to be supporting the child, the family, and the village that is raising that child. We need to think about open and honest communication, how we address collusion, how we talk to children and their families, how we talk about difficult issues. We know that there are many social issues. I've mentioned peer support, but for many it's time of loneliness and isolation. Many of our children will spend a long time in hospital. Many will be away from their peers. Many will be away from their friends. Many might be away from their families. How do we support them in their loneliness and isolation? Not just of the children, but of the family members. What about the stigma of having a child needing palliative care and the big impact on the families? We know that that siblings are greatly impacted by having a sibling who has cancer or who needs palliative care. What about the child and the family's inability to continue with what is normal? We've done work asking children what they want, and they want to be normal. They want to go to school. They want to continue social activities. So just trying to think, what are some of the unique needs of children in palliative care? Spiritual issues. Don't forget that children understand and feel spirituality. They understand spiritual issues. And how can we give them an environment in which to speak about it in an age-appropriate manner? And yet it's often hard for us to talk about some of the existential issues. Why me? Why have I got this condition? Why am I dying? And there are many useful concepts that we can use to talk to children and their families about some of the spiritual issues. We know that dying is a process, and whilst palliative care is not all about end-of-life care, we know that end-of-life care is a core component. How can we ensure that the families have the best experience of the end-of-life care that is possible? Do we have opportunities for advanced care planning? Are we able to care for them at home? And let's not forget the siblings. And in that, we think about grief and bereavement as well. And how can we provide services, not just to the parents, but to the siblings? How can we support the child who is dying through anticipatory grief? So how can we make sure our bereavement services are appropriate for the children that we are caring for? Communication is a big issue. We could spend hours on this, and I know you've talked a bit about this. How do we share bad news? How do we talk with the children? What is appropriate? What is seen as culturally appropriate? When do we challenge culture and when don't we? How do we support families? How do we develop trust, which is so key as we're providing palliative care? And that brings in the family and their significant others. Don't forget the siblings, but how do we support the families? And particularly when maybe the family is split as they're receiving care, not near their home. So let's remember the whole family. Let's think about the impact on relationships, the impact on longer term care for their brothers and sisters. And that links us into financial issues. We know that many families will spiral into poverty. That having a child needing care has great financial impact on the rest of the family. So siblings might not get to school. Family members might sell all their possessions to pay for treatment. And maybe some of that treatment is not appropriate. The out-of-pocket expenses, and there's been some great work done in Malawi looking at the financial impact and palliative care as a poverty reduction strategy. So many different issues. Teamwork is important in children's palliative care, just as in adult palliative care. So it's really important, just as we finalize, that we integrate children's palliative care into different settings. And there's a wide range of resources on our website looking at how you do this, giving links to some of these materials. And I know that through the ECHO platform, you have access to many of these resources. But we know there are challenges in providing children's palliative care. There is a lack of education, there's a lack of trained professionals, there's a fear of opioids and challenges with the use of medicines, and many different challenges that health workers face. And we could talk a lot about these. But a lack of understanding of what palliative care for children is and the need for children's palliative care. I spoke to one Minister of Health who said, our children don't need palliative care because they don't die. Sadly, they do. And so even our governments need education and sensitization on the need for children's palliative care. I'm sure you've seen this before, but this just highlights the lack of access to opioids. This is morphine equivalent, and you can see that much of the sub-Saharan African region is missing, as we don't have access to the medicines that we need. So it's so important in children's palliative care that we try to understand the illness from the child and family's perspective. We give children and their families the information that they need, and we really think about how we can develop and strengthen each of our healthcare professionals in providing such care. So just as I close, as I know I've had my time, what about in Lesotho? And ICPCN has worked with the Ministry of Health in Lesotho, and Joan was instrumental in setting up this program and supporting this program. They trained 28 people, developed materials for education. There was a First Lady's Declaration drafted, but I'm not sure if it was actually ever published. But there are a range of materials for children's palliative care that have been developed with the Ministry of Health, and we can ensure those are available if you haven't got access to them. So as I close, just a reminder that we want to try and help children and their families achieve the best possible quality of life. We want to relieve their suffering. We want to care for them with competence and compassion, and to accompany the child and their family on their journey, so that we can improve the lives of children like these children, and also through the case study that we're about to hear from Joan. She will bring all of these key areas to life through that case study. So I'm going to hand over to Joan. I'd like to thank you for inviting me to be part of this. And also, please do go to our website. If you're not yet a member of ICPCN, you can become a member and it's free of charge. And we are continually uploading new resources onto the website. Yeah, please do join us. Thank you.
Thank you, Julia. Thank you for setting the stage. I know that we are close to the end of this course, but I think it is really important to understand a lot of the concepts and the theories that we've been learning, and some of the practical advice that we've been learning also can apply to children. And I think you have really helped. We actually do have a little bit of time for discussion. So Joan, before we go to you, if there's any questions, Julia will be with us for a little bit longer, I think. So if there are any particular questions that you have related to children's palliative care, specifically related to the diseases, to trajectories, to yeah, anything and everything.
I see, Joan, you've been answering the questions, so thank you. We're used to working as a team, Joan and I, so.
Yeah, we go back a very long time, Julia and I.
I know.
Over many countries, many continents.
Yeah. Over
We're really
20
fortunate.
years.
Really fortunate to have you both on this call today. And they are both very approachable, so welcome to privately message them if you also want to connect further. Any questions from the group?
Just saying, we can both just talk about children's palliative care. So
on and on and on.
On and on and on. Yes, so it's probably a good job that we're just in a short time.
There were some comments in the chat about cerebral palsy. Julia, do you have a comment on how, if you come across a child or a family that has a child dealing with cerebral palsy, how to support people with that?
So there's been quite a lot of work done. Probably not published enough, but there's been quite a lot done in Malawi and in India and in other parts of I think in South Africa, Joan, as well, in providing palliative care for children with cerebral palsy. Now, of course, cerebral palsy, there's a wide range, isn't there, of children with cerebral palsy, and it affects children in a wide range of ways. So not all children would necessarily need with cerebral palsy would necessarily need palliative care, but certainly those with the complex conditions, I think they generally would be in the category 4 from those categories that I showed. So they would be more susceptible to other maybe pneumonias, other illnesses and conditions. So there is experience, and it is really important because they are often a group, those with severe cerebral palsy are often a group that get forgotten with palliative care. But it is getting the balance as well, because as I said, not every child, the child with mild cerebral palsy, you wouldn't need necessarily to provide palliative care for. But Joan, do you want to add to that? Because I know you've got a lot of experience in that area.
Yes, we do get a lot of children with cerebral palsy, and we find that TB meningitis is a major cause, traumatic injuries at birth, and often these children are very neglected. They're very difficult to look after at home. when you haven't got the resources, you haven't got the nappies, you can't get to the clinic for their medication. And so children who really should be able to live out a long life expectancy often die very young because of social and economic factors with the families.
Yeah, and then their risk of infection or
Yes,
basic
yeah.
disease ends up pneumonia.
And nutrition, malnutrition, difficulties with feeding, epilepsy, of course.
And if they don't have physio, you know, the limbs, yeah,
contractures,
needing walking aids, wheelchairs, often not available.
It's a major problem, I think, in all low resource countries, because certainly working in across Africa and Asia, you see a lot of children with cerebral palsy.
Can I just say, I think that I've just seen a thing about this is not an easy topic emotionally, and whilst it isn't, it is at the same time we can make such a difference to the lives of children and their family. And I always like to think, when we're thinking about children's palliative care, adults as well, but it's about living, it's about enabling the children to have the best possible lives that they can. And we have such fun, and we, with the children and their families, as well as it is emotionally hard. But you do have the two sides, and it is really rewarding.
Absolutely. And children live in the present. They live in the present moment. And so if you can do something to make them feel happy and good and like normal children, I think a lot of our aim is to try and help them to feel as normal as possible. And Dr. Stefan Friedrichsdorf, who's one of really the great leaders in the field, he always says, if you have a school-going child who comes to you with pain and other symptoms, the first thing you do is try and get them back into school so that they start feeling as though they're normal children. They are normal children, just they happen to have a condition and illness. And that's one of the great aims of what we do, is to help them to live as well as possible, as long as possible, and to help them to just be children as far as possible.
There was a question in the chat, and then Harriet will go to you, just related to birth asphyxia, how we support families. We'll go over this a little bit more in the case, but Julia, if you want to talk a little bit about, I'm thinking how to support families when something happens that they're not really prepared for. Obviously, we don't really prepare for that sort of emergency happening during delivery. So how do we come alongside families in a holistic way?
That is always a challenge, because, you know, the birth of a child is supposed to be a happy occasion. You know, you give birth to hopefully a healthy child. And so when something goes wrong, it is really hard. And we need to think about how best we can provide support to the families, not just say, there's been challenges, your child is not going to survive or whatever, not just kind of breaking the news in an abrupt way, but thinking about how best we can talk to them about it, how best we can support them. For those sometimes you know that there's going to be a challenge with the baby before they're born, so then you can think about it in advance. But it's really important that we train midwives, that we train obstetricians in palliative care, so that we train them to have some of these really difficult conversations and to provide that support for the families at that occasion. Now, there's a whole lot of work being done on neonatal palliative care around the world, and the evidence for that is continually developing and improving. There's work done both in high-income countries, but also in low-income countries, and in humanitarian settings. How do we provide that ongoing support? And how do we support people in that time that should be a happy occasion to be a challenging one? there is, so Alex Mancini in the UK has helped develop a course on the ICPCN e-learning site that's free, which is around antenatal perinatal palliative care, and we're just about to publish a more advanced course as well. So there is information available as to how we can support families.
We'll go over it a little bit more during the case, and Joan will also share some resources. But Harriet, do you want to have a question? And then there's one more in the chat.
It was a quick one around something that you said that really struck a chord when you say children also have an understanding of spirituality, and that's something we maybe don't think about when we are talking to children and their understanding around that. But I just wondered, when speaking to children about dying, about the fact that they are dying, because there is something in continuing to be a normal child when something else is happening to you. And I wondered how we can have that conversation with a child in a way that they are accepting that this is what's happening to them.
And you want me to answer that in like 1 minute?
No.
It was a quick, Julia, it was a quick question. Did you not get that first part? Harriet.
Do you know what? It is the whole talking to children about illness, death and dying is a challenging one. And it will depend on lots of different things. So one of the first things is that children aren't stupid. Children know what's going on around them, particularly children with cancer or children with HIV. Or children, you know, when I worked at Mildmay in Uganda, which is an HIV setting, we interviewed children and their carers, and the carers were going, oh, they don't know this, they've got HIV, and the child's going, of course I know I've got HIV. Everybody who comes to Mildmay has HIV. So, you know, there's so many examples of where children have a much greater understanding about what's going on than their parents or we as adults think they will have. So it's about exploring with them in an age-appropriate way what they know, what they want to know, enabling them to talk about it if they want to, but also trying to find out what they're asking. So, for example, I remember one child at Mildmay who was about 6 said, am I going to die? And you know, I don't say yes, you know, or no. I kind of was probing back with them and said, oh, you know, what makes you ask that? Well, I've just been given ice cream, and the child in the bed next to me was given ice cream and they died about half an hour later. So this young 6-year-old had equated ice cream with death. So that's really what she was asking. So it's about exploring what they know, what they want to know, what they're asking. So it's usually a process depending on their age. A child who has been ill since birth will have a very different understanding from a child who's been fit and healthy until they're 10 or 11 and then gets cancer. So yeah, there's a whole big course on how we do that. But key, I would say, is don't ever lie to a child. Building trust is important, and don't ever lie to a child. There's ways you can, you know, not be blunt and say something, but also not lying.
Thank you, Julia. The question in the chat was, what is your submission regarding the invasive procedures at this moment when we try to keep our children as comfortable as possible? I don't fully understand that, but maybe just along the lines of intensive procedures, invasive procedures, and how do we ensure that children are comfortable, but also...
So I guess I would, with any procedure, I particularly towards the end of life, but I would say, now, why am I doing this procedure? Is the care that I'm about to provide going to change if I know the answer to this? So, for example, if I'm taking blood, is what I do for the child going to be different if I get depending on the result? If it isn't, then I'd say, do they really need that procedure? But if it is something that really is going to impact the care that you're about to give, then I would think about it, and I would look at doing it in the most comfortable way possible. But that's with not just with invasive procedures, but with X-rays or scans. A, they might cost money, but B, a young child might need sedating to have an X-ray or a scan. Is the result of that going to make a difference to the care that we provide? So is it really necessary?
And I think sometimes those kinds of decisions can be made as a team. I think some of these things can be done in discussion with the primary provider, but then also as we get more palliative care teams formed in Lesotho and people empowered to come alongside primary care providers, helping and advising. Dr. Hassan, I'll give you the last question and then we'll shift over to the case. It's been really nice to have this time of discussion. I hope everyone is benefiting.
Thanks, Erin. Yeah, today's discussion is very important. And thanks for giving me the opportunity. It's just a comment or addition to Dr. Julia Downing and the other colleagues. Yeah, to me, like I think in a consultation session, always I have noted before coming to palliative care, that the children's thought and children's history taking part is always asked to the parents or the caregivers. It is for granted, always is something like that, where we missed some information. If we could get a chance to talk to the child who can talk, who can speak out, we could have get more information about his or her illness and other psychosocial component. That's only my addition. Thank you very much.
Talk to the child where you can. Even those who might actually not be verbal can still communicate. We've got one child who was actually had cerebral palsy in the refugee settlement in the north of Uganda. She couldn't speak, but her carer had found a way of doing a pain assessment on her hand, and the carer would point at the child's fingers and she would blink when they got to the finger demonstrating the severity of the pain. So there are ways, and the caregivers will know how to communicate with children who might not be verbal.
Thank you. All right, so now I'd like to introduce Joan. She obviously has had a few moments to share, but Joan is with us today and representing PalChase as our global network for palliative care in humanitarian settings, as well as Sunflower Hospice in South Africa. She's been with our team for the Lesotho program for the last several, I guess, weeks or months. And of course, many of you do know her. I'll share my screen and we'll hand it over to you, Joan.
Thanks, Erin. And thanks so much, Julia. Good to share a screen with you again. Just a little bit of background to the case study. We actually had 3 case studies that we were going to share with you. In fact, Prof. Jan du Plessis was going to share, and then Jan couldn't make it. And then right at the beginning, when Erin opened the screen, Tebelo told us of an in-the-moment case study, a case study that we really feel those of you living in Lesotho can help with. So this is for all of us. It's a brand new case study. It is a real case study. There's a mother and baby in Lesotho at the moment who need care and support. And so when we're going through the case study, I would like you to think of all the things that Julia has spoken about. Look at the whole aspect of total pain for the mother and for the baby as well. And just think about what you could do as palliative care practitioners in Lesotho at the moment. And so I think, Erin, you're going to have to move it forward. Oh no, here we go. You've had all of these in the past ones. Erin, I think yes, please, if you will just. So this case, this real case in the present moment is a month, no, I don't think it's a month-old infant with anencephaly. Is it a month? Okay. A month-old baby with anencephaly. And that's very unusual for these babies to live as long as a month. She's 19 years old. She's working as a housekeeper and she became pregnant. She's a single mom. And this little boy was born with anencephaly. He has no anal orifice and passes both urine and feces via his penis. So you can see there's a lot of genetic mutations in this child. She can't go home. She's rented a single room and she's not working, so she has no income. And she left the hospital against medical advice. These babies don't live for very long. And we gather that the hospital had advised her to stay at the hospital with the baby so they could care for them together until the baby dies. And she has been referred to social services for counseling. Erin, can you move it forward, please? Thanks. The infant cries a lot and appears to be in pain. And that, of course, is very distressing for the mother. And of course, for the baby is in distress. Next slide, please. So as we can see that while the team has advised her, she wants to leave. She wants to be discharged with her baby and possibly to go back to her family as well. Sorry, Erin, can you move it forward, please? Thank you. She's very young. Her mother's also young. She has recently delivered and is breastfeeding, and therefore she's not able to emotionally support her 19-year-old child. The 19-year-old mother and child live in a single rented room, but she has no funds to cover rent, food, or nappies for the baby. And so we're looking at this picture of actual total pain, aren't we? We're looking at this mother and the baby, social circumstances, family circumstances, psychosocial support, all of that is missing. So next slide, please, Erin. There was no coordinated multidisciplinary intervention when the mother and the baby were in the hospital. And so from the beginning, she didn't have that extra layer of support that palliative care would give. And the communication and the medical care and support has been done in isolation. So again, there's been no comprehensive team approach to the care of this mother and child. And if she goes out, we don't know whether there is any continuity of care as well. As I say, this is something that came to DeBello's attention today. Next slide, please. And of course, she's distressed. She feels lonely and helpless. I'm sure she's asking these questions. Why me? Why my baby? What has caused this? Have I done something to upset the ancestors? Is God angry with me? The guilt as well that she may be feeling. Next slide, please, Erin. So the questions we want to ask you to discuss in your breakout rooms, my apologies, my throat is giving problems, is in relation to the total pain model. So total pain, pain of the body, mind, and spirit within the cultural and social context. And we're asking you to look at the psychological aspects of pain and what you can do to help, the social aspects, and how can you, who are in Lesotho, actually respond very quickly to try and help this mother. This baby's in pain. How can you help this baby physically? And then, of course, the spiritual aspects. What resources that are there in Lesotho can you bring to help this mother spiritually? And what help is there for the mother? What financial help? What help with resources like nappies and clothing for the baby and simply food for her as well? So those are what we know about this particular situation. I just want to, I'll show it to you just now, in that Patch South Africa is the national network for children's palliative care. And we actually have a book that has been written by Patch. It's called A Better Care Book, and it enables people to work together as a group and to share knowledge. But I can share more about the Patch book later on, and I can send you the contact. And I have a couple of books that I can send through to Leostho as well, if there's anyone who would like to know them. But it is a perinatal palliative care book that you can actually use no matter where you are when a group of you want to learn more about perinatal palliative care. So this is really an issue of perinatal palliative care. It's an issue about the support for the mother and the care for the baby, looking at nutrition, looking at the pain that the baby is suffering, looking at the fact that this is a child who is going to die and is probably going to die very soon, and how that child can be helped to die as comfortably as possible. Tebelo, I don't know, you know more about this case. Would you like to give a bit more information?
I think Joan, thank you very much for presenting that, and thank you, Professor Julia. I think you have presented it beautifully well with the amount of information we've got. Our team of social workers that have had an encounter with this young lady, they are going to do their own social assessment of all the facts and details. But this is as far as they have got, which I believe is still got all the dimensions we can be able to explore and see how much support she could have. But this is the living reality of many of the families that have got children, whether there is complications related to the cancer or these congenital issues, or even HIV complexities. And like Professor Julia was saying, sometimes people, even at the high level of authority in nations, they will say, oh, our children don't need palliative care because they don't die. Just shows a lack of knowledge and awareness. And that is why advocacy is so important, to keep the information at the forefront, people to be aware of. So I don't know if any of our colleagues in the social development might want to add a bit of information that have not been shared in these slides before we all have the part to say on how best to approach it from all the dimensions. Anybody? Hello? Hello? Yes, team. My name is Matabo. I'm from Social Development Headquarters, Maseru. Thank you for the beautiful presentation. I just want to share the support we give as our department in the Ministry of Gender and Social Development. What we do with in regard to children with cerebral palsy and autism, we offer counseling to families. And besides that, we also offer them assistive devices like the standing frames, the supportive seats for children who can still sit, and colostomy bags for those with incontinency, and then also food packages for poor families. And then we also provide medical fees for families who cannot afford to pay for their sick family members. There is also public assistance in cash, which we give to poor and ultra poor families. We have also introduced disability grant, which we have piloted in 5 districts. And we are in the process of expanding to the other 5 districts so that we cover the whole country. We also offer training for carers of children with cerebral palsy and autism. They also have their associations. There's Autism Leostho, where these groups of parents of children with cerebral palsy and autism, they come together and they do the peer group discussions where they share their challenges together with the support of the social workers. The trainings are facilitated by the social workers most of the time. So most of the time, some children, they die without getting support because they are not reported. Most of the cases we are not reported. So if we don't know about them, then it's a problem. We work together with the occupational therapist at Queen Mama Hato, who is helping us with the assessments of these children. And I think that's all I can share for now. Thank you.
Thank you. Thank you so much for taking time to explain that. And it is really good to hear about the different opportunities that people have. Tabello, any final thoughts before we move into our breakout rooms? We actually have quite a bit of time. So I was thinking we could go in our breakout rooms and then we could actually come back and do 10 minutes of discussion together as a group, just to hear if there's some ideas that can be taken back to the care team.
Thank you, Erin. And thank you, Mema Tabo, for sharing all that information that is on offer to support our people and their families. And I really, really want to emphasize the very core of what palliative care is all about, which is the multidisciplinary approach, which I believe with all the good elements and the care support that is available within the social development, I believe that could be enhanced even more if then we have got the coordinated kind of approach whereby we will be having clinical social workers within the district health teams. Then it means that we will close the time gap that it takes for the physiotherapist in Queen Mama Hato to do assessment and then refer to social development, and then the caseload, and it's picked up whenever they get to that file. But if the clinical social workers, it can be appreciated that they are very core essence of what will make a difference in the lives of patients and their families, so that they are at the first instance in the hospitals. As this complex issue arises and needs attention, there's a doctor in the team, the nurse, the pharmacist, the social worker, occupational health therapist, physiotherapist, any other, and the chaplains or pastoral counselors. Then we know that immediately we devise a plan which will work for this patient and the family in a comprehensive manner without delay. Because what happens in palliative care, we haven't got a second chance to make things right. We only have one chance to make things correct. Therefore, the time is what kills me, because many of the people fail to get support because of long dragging processes that we have, because we haven't got the coordinated kind of approach to make this case a priority for us at an instance of all of us around the table to discuss what is the best approach. So, however, I still appreciate that there's a lot that you are doing, and we are grateful, and we still believe with all this awareness that we are doing on these sessions, then we can see how best we can move forward in collaboration with our Ministry of Health to make your job that you have stipulated so beautifully of all the great efforts you are doing, so that we can enhance and work together or as a whole multidisciplinary team. So thank you very much, Erin. And I like Professor Downing, because she highlighted anticipatory, grief as well as a bereavement. And we don't have bereavement services in Lesotho. Completely no bereavement services. And again, the advanced care planning, we don't have such. So those are the things that when we advocate, they are at the core of what we want to see as a change. And we are very grateful with the team that is joining the trainees and showing interest, because we believe that there will be advocates in their own right, in their own disciplines, and we can work together to bring about the change that Lesotho desperately needs. Thank you.
All right, so let's take a stretch. We have been sitting for like an hour. Everyone, both of my kids are awake, and it's 9 o'clock here in Kenya. They're sleeping on the couch behind me. But we are going to go and head into our breakout rooms. We have 2 faculty members that will go into each group. Each group has about 9 or 10 people. So it's a small enough group that if you feel comfortable, you can turn your video on. You can also show us all your children in the background, because I know it's nighttime in Lesotho, and what TV show that they're watching. But I would like everyone to come up with 2 things that they would suggest for this case, what you are going to share, and then choose one individual from the group to be able to share about a minute or 2, and we all come back together. So go have fun, make a joke. If you're into Bella's group, make sure she doesn't talk too much. I'm joking. Bye, everyone. I said my kids are not sleeping.
So you're like,
What TV show are you guys watching?
You should have it.
Oh dear. Welcome back. Hope you had a good chance to connect in a smaller group and talk about the case. A few people dropped off the call. I think sometimes the network isn't so reliable, but it seems like we did have quite a few people that were able to rejoin us. So we were 5 groups. So we'll allow each group to share for just a few minutes. And yeah, it'll be great to hear some of the suggestions, recommendations, reflections on the case. So do you guys remember which group you were in? Group number 1, do you remember who you were? Oh dear, I also don't know.
I think was that us, Harriet? Were we group 1?
I didn't look what number we were.
Oh, sorry.
But we did have a volunteer to report back. So maybe whichever group we were, perhaps our volunteer would report back.
Yeah, I didn't look at what number we were in.
Oh,
either.
sorry, I should have said that. Doesn't matter. Okay, who would like to go first? We have a brave individual.
Yeah, I think we were 5. Huh?
Okay.
First, because you've pointed us. So
Okay, welcome. Go ahead.
But we did have a volunteer, didn't we? Only I can't remember who it was.
I'm looking for her and I can't find.
It's Mema Mokit if she's still comfortable, or else I can.
Yes, was it?
If you go ahead, because you did grasp some of what we were saying.
Oh, okay, thank you very much, Tim. We were supposed to look at the 5 aspects, right? And to looking at the situation of this 19-year-old girl, we thought maybe if we can look at the social aspect first, we meet her social needs before we can do anything else for her. We said if at least there can be social workers in our hospital settings, so that she can be affirmed that now that you are living in a rented home, there's no food, no clothing for your child, no medical fees and everything. There's a department that can cover all this, your needs. And then if she has been assured of this, then from there we can build a rapport, because we remember this girl has no one to support her. There's no, the father of the child, there's no parents, there's nobody. So if she's assured of this, her needs, that they are being taken care of, then that is when we can come to the psychological aspect. Then we deal with her emotions and all those that other needs. Can somebody from our group chip in, please?
Yes, because we were looking at what is her immediate need, because she already left the hospital where she was offered support. So we kind of like just explored why she would have not accepted the support from the hospital, and wondered about what sort of compassion she had received from the hospital staff, whether there was an element of her actually being in so much distress around what's happening and not getting the compassionate response that would have helped her to actually feel secure in that environment. And so just thinking actually, but we also felt that this young woman and her baby are at risk at the moment, and that actually somebody needs to engage her in a way that she will feel secure, in a way that she can be helped to make the decisions that are in the best interest of herself and her baby, which she hasn't been able to do for whatever reason. And starting and looking at Maslow's hierarchy of needs and thinking, actually, let's look at the basic needs as a way, as an in to actually then understand the whole picture for what's going on for her.
Yeah, that's great. I think we'll definitely make sure that as Tebello goes back to the team, that she continues to reiterate the basic, needs of life for this woman are really, really important. And if there is some way that they can connect to social services in her area, great, perfect. Group number 2, or the second group, who would like to share? Someone would like to go next. We're running a little bit over time, so we may need to cut it down a bit shorter to maybe a minute.
Ian, we were number 2.
Yeah, we can go next. Shall I speak for us, Joan? Okay.
Please.
So we I guess started off with a number of observations and questions. Like group 1, we were concerned why it was that the mother felt unable to stay in the hospital, and whether that was related to her perception of what the hospital was like or her experience of being in the hospital. We felt that it must be extraordinarily distressing for her, not just having an ill child and a child with a very limited life, but a child who must look physically very distressing to her and to anyone providing care, and that may make her feel even more isolated, even though she's already in a very isolated situation. We felt that the description of the child's physical problems made this really a crisis emergency situation, that the child's life was going to be measured in a few days at most, particularly without supportive care for feeding and so on, and the risk of infections because of passing feces and urine through the penis, and the possibility of bringing that care to mum in the community, to mum and baby in the community, is very, very limited. And really this child is probably, or child and mum would probably be better cared for in a hospital situation. So we, in terms of what we wanted to do, we wanted to explore with mum what it was that had caused her to leave, and whether there was any possibility that she would accept readmission to the hospital for that care for herself and for her baby. The other thing that we thought about was I guess comparing the situation with others that we've known, whether or not we felt there was a safeguarding issue here, that an extraordinarily ill child had been discharged into the community, albeit mum had self-discharged. That clearly wasn't, that the child wasn't able to express a position on that, and we felt that if that had an appropriate safeguarding procedure being implemented in the hospital, is that something the hospital need to reflect on and look at as part of their assessment of what went on in this case? And were there safeguarding procedures that might also support any action taken to return the child to hospital for care?
Yeah, those are some really good points to Bello. I see you're making notes. I hope you are. But actually, I was also thinking, as you mentioned, that Dr. Ian, actually, she didn't abandon the child, which is interesting, right? There could be situations where we are facing family dynamics where it's just actually too much and they need to leave the hospital. So there is that interesting dynamic, but I totally agree. She also probably could be dealing with postpartum depression. And because she's single and not able to probably even provide for her own needs, it is really risky. I mean, really serious. Okay, third group, we're gonna have to do rapid fire. Thank you. George, would you like to go next? Oh, you're muted.
Sorry, so sorry. We Matavang Melise very kindly agreed to present for us.
Oh, thank you very much, the group. One of the things is we can provide the counseling to the mom, since she's a teenage mom and her background family is not very good. Her mom is having, she's having another baby, and they're poor, and then maybe she doesn't have a husband to give her emotional support. So we think she needs counseling, and also the condition of the baby, it is also not good. Also, we can give, as for the baby, we can keep the baby clean, and also try to feed the baby. And also we can also try to give some opioids to relieve some distress. I think that's the care that we can give for both the baby and for the mom. I'd like my groupmates to try to add if there's something that I missed. Thank you.
Could I add? No, that's exactly right. Thank you very much indeed. That was very absolutely right. I think, can I just share with the group that when we first started the discussion, there was a sense of being overwhelmed by the challenges that this situation gives. And I think we had to step back a little bit and think, how do we first of all deal with that sense of hopelessness about our own ability to help here, in order then to move forward and to come up with something that was going to genuinely be helpful. And I think that's something that we agreed we wanted to share with you all. There's no answer to that, but we felt that this was going to be extremely challenging to everybody, but that social workers here held the key because of their ability to offer something more than we could offer her medically.
Thank you, team. Thank you. Are we on to the fourth group? Tabello? Unmute.
In our group, we have got Melrado to represent us, please, if she's still on the call. I can't see her because some people fell off the system. Melrado, are you still there to represent us?
Oh, yes, I'm still here.
Go ahead when you.
Can you hear me?
Yeah,
Yeah.
great. Go ahead. Welcome.
Thank you, everybody. My name is Leostho. I'm a social worker working in the Ministry of Social Development at Masero District. In our group, we decided to talk about the psychosocial elements and spiritual elements. In the psychosocial elements, we decided that the mother needs, because first of all, she is really nice and.
1 minute, 5 minutes.
Can you hear me?
You are breaking a bit.
Is it my network? My network has a problem.
Yeah, try
But
again.
am I clear now?
Yes.
Yes. We were going to talk. We talked about we looked at the psychosocial elements and the spiritual elements. In the psychosocial elements, we said we were going to give the mother needs counseling because first of all, she is an adolescent. She's still an adolescent. She's supposed to be out there living her life, being young, but now she has a baby, and having a baby, she has a baby with an illness. So this must be weighing on her psychologically. So she needs to go through extensive counseling for her to accept her fate and accept what has happened to her. Also, her family is also suffering because of what is happening to her. So we need to make a family gather. There needs to be a family gathering. The whole family needs to go through counseling because of what is happening to them, and also establish the relationship between the mother and the child, because obviously there must be some kind of breakage in the relationship if they are both young mothers, they are both having children, so they both to be dealing with the same problems, and I think they both have relationship problems, so they need to be dealt with. Also, we need to look at who made this girl pregnant. What are they doing? Are they taking responsibility? Why is she so poor yet she has a baby with somebody who could be taking responsibility? So we should take the legal route and look at the responsibilities of the other parent. If I am leaving anything, my group mates will pitch in. Spiritually, we think the girl has guilt, she's hopeless, and she is full of self-blame because maybe she's asking herself, what did I do? Why me? Did I do? Start questioning God, start questioning her spirituality. So she needs to go through spiritual counseling. She needs to make peace with what happened to her. She needs to understand.
Thank
Has she
you.
fallen off?
I think so.
Oh,
I think it's definitely really interesting as we reflect as a group on this. Of course, in the moment, while you're providing direct care, it's probably really hard to think of all these ideas. So this is a really good tool and technique to kind of debrief cases and think of all different possibilities. They might not all work, but it is really good to bring them all to the table, because in a case similar to this, it might work. And it might be something that would really provide support to the family. Okay, our last group. Some suggestions in the chat, which are really good, using pain scales. Do we have a comment from the last group?
Okay, thank you so much.
Welcome.
Yes, the other groups have already said it all, but I think what we can just add on is that the lesson that we have learned from this case going forward, we asked ourselves as to where does palliative care starts, and we realized that palliative care starts immediately when the diagnosis is made. So meaning that immediately after the doctor had told the young mother, that is where palliative care would have started, and we should try to use a multidisciplinary approach right there, meaning that the lesson that we have learned is that maybe through effective collaborative approach, maybe we think or feel that the mother should not have left the hospital because that is the place that we feel that was best for her and for the child, meaning that she might have insisted to leave because of the trauma and the stress and the social circumstances at her home or where she lives were not taken into much consideration. I think that is our addition from the group. Thank you.
Thank you so much. Thank you, everyone. I think tonight we've had quite a lot of time to reflect and engage as a group. I think Tebello has a few notes to bring back to the team. Thank you so much also for the team bringing this case forward. Talking about difficult cases isn't easy either. And of course, we together as a team here are wanting to work together to find ways to support you. We know we've stayed over a little bit. I hope today the breakout rooms were good. We have one more session and we are so proud of you. You guys have stuck out weekly sessions with us on Tuesday nights. We will be starting a second batch of some of your other colleagues who weren't able to join us this time. But yes, thank you so much. We will end our call now. And please join us for the last session next week on neglected cancer care needs in Lesotho. And we'll be having Tebello present next week. So we're quite excited. We'll explain a little bit more about the certification process after the last call and what's required of you. But thank you again for your commitment and for everyone who was with us tonight. Good night, everyone.
Thanks again. Bye.
Thank you. Bye.
Bye.
Thank you.